you so much for inviting me here. And when I saw that the first presentation was going to involve a patient, I was really thrilled. I think virtually all healthcare conferences should start off that way. I think it keeps us grounded, and I think it really helps us to make sure that we are focused on what is important. Just quickly, show of hands, when I say the phrase meaningful use, does that create a deer in the headlights kind of reaction, or is that something that you're at least vaguely familiar with?
Which set of hands are you
Okay. If meaningful use is something that you're at least vaguely familiar with, please raise your hand. Okay. Great. Okay, and I will explain more about it. It is basically the framework for the incentive program that the United States used for encouraging not only use, but meaningful use of electronic health records. But it really is not about technology. I don't have to tell all of you about winter. When I first arrived at ONC a little over 4 years ago, now, this is going to sound pretty silly, but we actually had some pretty bad snowstorms that year. In Washington, we labeled it Snowmageddon. We had 3 storms of more than a foot each, which by Washington standards pretty much grounds everything to a halt. So you can think of there being snow and there being meaningful use of snow, this nice snowman. We move from winter to spring, and grass starts to grow. I'm Washingtonian now, but I grew up in Boston, and in Boston, there's nothing more important or more meaningful use of grass than Fenway Park, where the Boston Red Sox play. And then in Washington, you move on to summer, and in summer in Washington, you get these tremendous thunderstorms. So the dirt turns into mud. It turns out, actually, that mud is actually a mathematical equation. It is meaningful use, MU, the product of meaningful use and dirt produces something like this. Now, the reason why I have put these down there is to demonstrate the difference between having a technology and making the meaningful use of that technology. It is not about the technology, it is about what you do with it. And so this is sort of the framework for what I'm going to try to do in the next 25 minutes. I'll try to actually cut it down a little bit to leave plenty of time for some discussion. What I want to just quickly do is make sure that everybody is on more or less the same page. It was actually exactly 5 years ago this month, in the middle of the United States' big recession, labeled the Great Recession, that we actually had this opportunity because of this stimulus bill that passed. The stimulus bill was labeled the American Recovery and Reinvestment Act, and really this was part of the reinvestment. This was saying, okay, in addition to time, this isn't really so much about stimulating economic activity, although obviously that was a part of it. This is actually about reinvesting and creating infrastructure that will allow us to be stronger as a nation. Now, the core concept, again, is meaningful use, and basically what we were trying to say, and in Washington, D.C., there's a sarcastic phrase that comes about, which is basically Congress in its infinite wisdom, which, as I said, is almost always used with sarcasm. In this case, Congress actually got it right. Congress said, we are not going to provide these incentives for hospitals and doctors to do the same bad processes faster. And just digitizing the information may create some vague efficiencies, but it's not actually going to fundamentally change things. And in order to fundamentally change things, people have to make meaningful use of that technology. I'm going to actually skip right over this, except in terms of the background, but I do want to make a point just using one study as an example. This is some research from Cleveland that came out a few years ago. And unfortunately, it's covered up a little bit, but there we go. So you can see that in terms of, for patients with diabetes who got all of the recommended care processes, you can see that those practices using an electronic health record were several times more likely than those using paper to ensure that those patients got all the recommended care processes. Now I'm going to make just a few comments about this. First of all, despite that tremendous difference, 51% is pretty lame, right? 51% is pretty bad. And we shouldn't be saying 51% is a lot better than 7%. We should say, where's the other 49%? And so that's the first thing. The other thing, though, I want to point out is that when you look at this next slide, you start to realize that some of the intermediate outcome measures like cholesterol control, blood sugar control, things like that, you can see that there's a lot better performance. As you get to some of the more behavioral issues, so go all the way to the end and you look at actual BMI, you can see that there's no difference. And this is a purely hypothesis as to what the reason is, but part of the reason is that this study was actually prior to meaningful use, and it did not include any access for patients to their records, and it didn't include any access, patient portal access. And so when we're looking at outcomes that are related to health behaviors, we're going to have much poorer performance if we're not finding ways to make sure that the data gets in the hands of patients when they're trying to make those behavior changes. This is a family practice doc in the middle of rural Wisconsin. His name is Chris Toshin. And he is an example of a doctor who, when meaningful use came along, he said, this is really important. This is really helpful. And the reason was that he said, for years I've been thinking about implementing an electronic health record, but I didn't know if I got it, if it would do the things that I wanted it to do. And part of what meaningful use did is it said, okay, there are some baseline things that an electronic health record is going to have to do, and now he knows that those things will be there. And this is just one very basic example of something that he said he couldn't do before that he could do, which is that there was simvastatin for treating high cholesterol. There was some new drug interactions that were identified, and he had to quickly figure out a way to let his patients who are on simvastatin know that they needed to reevaluate their drug choices. And so he, instead of kind of doing it in a manual way, he was able to quickly identify all of the patients who were on that and immediately get letters out to them. Or in the future, he actually will be able to do it electronically and connect with them about that and sort of get to that. I'm going to skip through some of this. Let me just make a point, though, about where meaningful use fits in, because meaningful use, the EHR in the clinical practice setting is actually just one piece of a broader electronic infrastructure. HIE is our term for health information exchange. And the combination of the meaningful use of EHRs with the exchange of that information from one provider to another, and ultimately from providers to patients and to other places, creates a liquidity of that data that then allows it to flow. And once you have that platform of data flowing, you can then begin to look at some key process functionalities. And these are just some examples: care coordination, quality measurement. But once you have those basic process functionalities done, you can move towards better outcomes. And to some extent, this is actually the framework for meaningful use was built in a staged approach. And so when meaningful use was implemented, it started with stage 1, which was a set of requirements. Stage 2 is a higher level of requirements, and then stage 3 will ultimately try to move towards really better outcomes. You probably can't read the slide. I just want to make one other point. about the context for this. So a year after the American Recovery and Reinvestment Act passed, the United States passed the Affordable Care Act, our health reform law, which does many different things. One of the things that it did was it created a national quality strategy. In that quality strategy, we started off with the triple aim. So for those of you familiar with IHI, that was brought up before, it's basically those same three aims. But then it said, okay, we are going to focus on 6 priorities. Now, you could make arguments about what are the most important things. But what the US decided to do is to say, okay, we are actually going to say we need to focus on 6 things and not more than 6 things right now, because if we don't focus, we will not get anything done. And so we said we're going to, 1, make care safer, reduce errors. 2, try to improve affordability of care. 3, improve coordination and communication. 4th, improve the dissemination of best practices. The 5th one was really around focusing on the best treatment and prevention strategies for a particular condition, the condition that kills more Americans than any other, cardiovascular disease. And then finally, ensuring that each person is engaged as a partner in their care. And that, through that framework, as we went about moving forward on what the definition of meaningful use would be, we said, if it doesn't meet one of these 6 priorities, it doesn't belong in there. People have far too much to worry about in this transition of our delivery system. We can't put in things that are not the top priorities. And so what I want to just do is then say, okay, if we had that, right, that number 5, the one there that about improving cardiovascular disease, let's just walk through what are these things that are in meaningful use. And we said, well, first there are a series of data elements that if you want to ensure that there are fewer premature deaths from heart disease, these are some of the basic data that you need to have, right? You need to know about smoking, blood pressure, BMI, problem list, med list, lab data. You also need to have some basic care processes in place, the ability to electronically measure clinical quality, some basic clinical decision support systems, and registry functions, so we can make lists of patients with those conditions. Second national quality strategy goal around safer care, reducing errors. So in addition to the things that were already there, we're going to add a few other core care processes, right? CPOE, drug and drug allergy interaction checkers, and electronic prescribing. And in stage 2 meaningful use, EMAR, electronic medication administration record, so that ensure that the right drug and the right dose is given at the right time to the right patient. And then in addition to that, we have to ensure that we're figuring out ways to engage patients and families. So in addition to the things before, we're going to make sure that every patient leaves the office with an after-visit summary. We know that 40 to 80% of everything that a doctor thinks he or she communicates to a patient in the context of a visit is gone by the time that patient gets home. And so doctor says, I told them to do X, Y, and Z. That is a lot of information that transpires in the average in the United States 16-minute primary care visit. Usually they cover 6 topics in an average visit in the United States in those 16 minutes. That is a lot of information. So it's really important that the main information be summarized. Patient reminders to remind patients about key either preventive care or follow-up care that they need. And patient-specific education resources. So linking diagnosis codes, procedure codes to specific patient education so that information is prescribed to them just like treatments are prescribed, medications are prescribed, et cetera. And then importantly, that there be availability for patient copy and online access. That was in stage 1. And in stage 2, the ability to view, download, and transmit that information so that the patient, the family, can get the information and or have it transmitted to to someone that they choose in a structured format and in a human-readable format as well. And also secure messaging, which is secure email between clinician and patient. Now, I also want to make a point about another important change that happened in this stage 2, this second, which is actually going into effect this year in 2014. In the past, things like patient copy and online access, basically they were things that the providers were responsible for making available. It doesn't mean that they had to tell the patients about it. And if that happens, what do you think is going to happen? Right? So we had a lot of zero denominators, which is to say that we had a lot of doctors attesting successfully to meaningful use who had 0 patients who came to ask for their records. So in stage 2, what we said was providers are actually not only do they need to make these available, they actually have to have a percentage of their patients use these things. Because the only way to ensure that they were going to promote these things to the patients, I sometimes get a little bit animated here. I have a lot of passion around this. I don't want to suggest that clinicians in general don't care or that they, or that there's a lack of support or anything like that. But in a lot of cases, the way that the system is set up in the United States does not promote systems to take the time to do these things, and because of historically a fee-for-service delivery system, it doesn't promote sort of free provision of information and service to people. And so it was important that there be a requirement that a percentage of patients actually did go online to access these information and did go and message their providers and send secure email. And then finally, more coordinated care. And again, a lot of the things that we've said before apply, but then also medication reconciliation and sharing a care summary, which again, in stage 2, it's an expanded transitions of care summary. I mean, this is just absolutely critical, and that information can then be shared. And critically importantly, shared across providers and across vendor boundaries. And this was a huge part of trying to improve interoperability, and something that, in the United States, this cannot happen soon enough. The data is so siloed from one institution to another, and we have got to get to a place where that data can flow. Otherwise, we cannot ensure that people are getting the information that they need when they need it. So I just, returning to this country doc in rural Wisconsin, and what he said is that what meaningful use meant for him is that he had this roadmap, and he had a roadmap for how to get from where he was to where he wanted to be. And, there are big integrated delivery systems like Kaiser and Geisinger and Group Health that have a lot of infrastructure to develop their own processes for how they're going to get to where they need to be. But if you're a 2-doc practice in rural Wisconsin where there are a lot more cows than people, you need some guidance and you need a roadmap, and this was something that was really valuable for him. I'm going to, again, skip through some of this stuff because we talked about a lot of it. And I want to leave some time. And I'm even, so my old boss, who was the person responsible for health IT at ONC, Farzan Mostashari, really talked about this issue of walled gardens, and I'm not going to play it for you now, but basically that we have to move beyond this idea that you only need to be able to exchange information within your delivery system, within your data silo, and it's really important to move beyond that. I just want to say a little bit about stage 3, which is going to be coming in another couple of years, and some of the things that are being discussed. Really trying to enhance clinical decision support and try to deal with some of the usability issues around that, and to ensure that there are ways of having follow-up from abnormal tests, things of that nature. On the patient family engagement there's something in the United States now called Blue Button, and all it really means is that there is a way that patients can basically access their information. And in the U.S. Veterans Administration, there are, I think, 1 million veterans have now accessed their information this way. And there are now many private sector organizations that are adopting this. But the idea in the future is to have an automated Blue Button that is a preset way, so that whenever somebody comes and wants their family member or themselves or anybody to be able to get that access, it's actually preset so that when the information pops back into the system, it actually goes directly to the patient, and that actually will speed up the delivery of that information in an appropriate time. So you may have noticed when I came up here that I was wearing this jacket. This jacket, for those of you, how many of you have heard of Regina Holiday? Okay, so Regina Holiday is a person who is an artist who had a husband who died at 37 of kidney cancer. And her story about that, her experience with that, activated her in a similar way to, I think, how your family has experienced something tragic, and then she has used that to try to help drive change. Because she is an artist, she used art to tell her story, and then she realized this could be a powerful way for others to tell their story. And the fact is that everybody has a story. And so if you go to certain conferences in Washington, D.C., you'll see literally hundreds of people. I mean, there are over 200 of these jackets now, and each one tells a story. And so these are my parents. My mom, a native Canadian, born in St. Catharines, and my dad. And one day, my dad, completely out of the blue, got very sick, so sick that he, over the course of an hour, basically became delirious. It turned out he had sepsis. Still, they don't know what happened, why. And luckily, my mom was there. If my mom wasn't there, my dad probably would no longer be here, which is a little foreshadowing that this is a happy story. So what happened is that I was in Washington, D.C. When I learned this happened kind of in the middle of the night. When I learned about it the next morning, I didn't know, should I rush up to Boston, where my parents lived, or what should I do? Well, the kind of lucky thing was that my father was actually in Beth Israel Hospital, part of Beth Israel Deaconess Medical Center. And as many of you may know, John Halamka, the CIO, who about 15 years ago created a patient portal called Patient Site. And it means that patients, or in some cases their family members, can get information about what's going on in their patient or family care. So I got in touch, I know John, I got in touch with him. I had my mother's blessing so we could get quickly through my mother wanted me to be involved as much as I could, so I had authorization. My father was not, at that point, competent to give authorization, so my mom, being his proxy, was able to grant that. And within about 20 minutes, I was able to follow virtually everything that was going on with his care. So when and there are a lot of things that could have happened. Now, they in many ways gave great care, and after a couple days in the ICU with antibiotics, he was back to not quite where he was, but very close, and everything. There were no huge problems, but there could have been, right? I mean, he has atrial fibrillation. He's on Coumadin, a blood thinner. If they didn't know that could have been a problem. My mom, given everything that had happened, who knows if she would have remembered every medicine that he was on. So it was a way that there could be a give and take, a communication between me and the nursing staff in the ICU. They also, of course, there was no interaction for a couple of days between his primary care doc, who's not a BI doc, and the hospital. So I was able to talk with both the primary care doc and the nursing staff and make sure that information was shared, because there was at that time, no way for that to happen. So that, again, in addition to the ability for me to help to ensure that there weren't huge problems, it also created a lot of a sense of comfort, and I don't think we can underestimate that as well. This is actually something that on the HHS, our blog at ONC, that I actually blogged about, and some of the comments that came in were actually much more informative than what I wrote, so I encourage people to check that out. And so I want to just close by saying that I know meaningful use, like clinical value, can be an arduous process. And so I just know that from my own personal life, because I'm a marathoner, that there is something very satisfying about making meaningful use of those things that are really important. Thank you.